Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Welcome again to the 8th educational webinar. This webinar is organized by the Iraqi Stroke Network and endorsed by the MENA Stroke Organization. Today, we have an expert speaker in the field of interventional neuroradiology. He will talk about a cornerstone topic in the modern stroke treatment. For me, my name is Mustafa Al-Shahni, a neurologist at Diwan Teaching Hospital in Iraq. In the Iraqi Stroke Network team. Now I leave the word for our panelist, Dr. Tamim Majid Al-Tamimi. Dr. Tamim is a consultant interventional neurologist and the head of interventional neurology department at Saad Al-Watri Hospital. And he is a member of the Stroke Disease Advisory Committee at the Iraqi Ministry of Health. Dr. Tamim, please, the word is yours now.
Welcome, everyone, in our webinar through the Iraqi Stroke Network. I would like to thank everyone for participating. Our guest today is Dr. Mustafa Mansour. He is a Dr. Mustafa Farid, Mustafa Farid. He is a professor of interventional neuroradiology from the University of Ain Shams. He is the head of Department of Interventional Radiology. He is one of the pioneers of Arabic world about the interventional neurology and supervising many research about the master and doctoral research for a master and doctoral degree in higher education. He works in the hospital of Ain Shams and also in many other Egyptian governors. I would like to invite him to give his lecture today about the treatment of stroke through interventional radiology procedure.
Thank you, sir. Thank you, sir, very much. Now we invite Dr. Naqaa to tell us about the Q&A section.
دكاترتنا الأفاضل، زملائنا وزميلاتنا الأعزاء، السلام عليكم. Welcome in our 8th webinar of Iraqi Stroke Network. I'm Dr. Naqaa from Neuroscience Hospital. I'll be the director of your question to Dr. Mustafa Farid. Please be free to ask any question in the chats below or choose the button of raising hands for comments after the end of the session. أهلا وسهلا مرة أخرى.
Shukran, Dr. Naqaa. Thank you. Thank you very much. Now we proceed the mic to Dr. Mustafa. Just let me share the screen, sir.
Thank you very much. I'd like to thank you, Dr. Mustafa, Dr. Tamim, Dr. Naqaa, for your welcome. And I hope this lecture is useful to all of you. This lecture is intended for the intermediate interventionist. Okay, if you are a beginner, okay, it will be very useful for you, but it will be very, very useful for you if you are already starting or beginning to join and participate in actively in mechanical thrombectomy for acute stroke. Next slide, please. So this is what we see in conferences. We see the occluded artery. Next. Then this is the wonderful result after recanalization. And everybody says it is very, very simple and it is very straightforward. But I'm afraid this is not the truth. Next. You can see here the red arrow points to an internal carotid artery termination. And this is a more complex lesion than before. Next. And this is after recanalization. If we go back, please go back. I find what is a little bit frightening about this image is that after the occlusion, everything after the occlusion is unknown. We do not know it. We do not see it. And this is the part where it becomes a little bit scary, and it needs experience, and it needs gentle maneuvers and delicate maneuvers. Next. Next. What about this lesion? This is a lateral view showing an internal carotid artery supraclinoid segment occlusion, and above all of this is unknown. Next. This is after the recanalization. Next. Another case, we can see on the right-hand side, total occlusion of the beginning of the internal carotid artery. And the other image shows the result of the treatment. So all of this is unknown. So you have to have like a very, very clear mind process what to do to obtain the best results. Okay, let me start now the lecture. Oh, this is an image. It's not from Google, it's from my camera. And this is a city in Egypt. It's called Alexandria. For those of you who have not visited Egypt, I will post a few photos from my camera to make you feel at my home. Next. Okay, what is the golden step before you attempt to do mechanical thrombectomy? You have to arrest the flow. There must be no flow in the arteries. Why is that? Because when you are pulling the thrombus out, this is in the opposite direction of the blood flow. So it will be more efficient and more easy if you arrest the flow. In Europe and in the USA, they use a balloon guiding catheter to do this. In Egypt, we have balloon guiding catheters, but they are very limited and also very expensive. So we use a method by using a regular guiding catheter, but it has to be a very big guiding catheter, like an 8 French guiding catheter. And we climb up and wedge it in the petrous segment of the internal carotid artery, so we achieve arrest of flow. This maneuver is very good to arrest the flow, and I find it more simple than the balloon guiding catheter. Next. This is the image we see in the books and in the YouTube videos online on how stent retrievers remove or take out the clot. This could be right, but there is a better way to do this. Next. If we compare this image to the previous image we just saw, the clot here is situated in the proximal part of the stent retriever. And this is a very, very important point to do, because when you pull the clot, part of the clot will be fragmented and it will fly away. If you have a considerable distal length of the stent retriever, this distal length will catch the clot. Let's go back to the previous image. Now let's go back to the next image. I think you can see the difference and understand me. Next. Okay, another point on how to be efficient. Some articles, like this article in the American Stroke Association, they suggested that you land your stent retriever in the more straight artery, in the lower branch or in the parietal branch, because this will achieve a more straight configuration of the stent retriever, and it will allow you to remove better and engage better with the clot. So when you pull it back, it will pull back the clot. Next. As we can see on this image, this lateral view of the brain arteries, the middle cerebral artery, we can see mainly two branches. One branch directed towards the frontal lobe, and we can see two other big branches directed to the parietal and temporal lobes. The article suggested if you want to do a successful thrombectomy, you have to choose the most straight branch of these. Yes, like you are pointing. Thank you. Next. And this is a very interesting article from Turkish doctors. Next. This article suggested that it does not have to be the straight branch, the more straight branch, but it has to be the more dominant branch. In the middle cerebral artery anatomy, we usually have a bifurcation, superior branch and the inferior branch. And these branches supply the frontal lobe and the temporal lobe. Regarding the parietal lobe, it could be supplied one time in one patient by the superior branch and in another patient by the inferior branch. So he could have, one patient could have a superior dominant branch and the other patient could have an inferior dominant branch. And another patient, a third patient, he could have a trifurcation. So the Turkish doctors suggested that the successful pass happens when you place your stent retriever in the dominant branch. Of course, if you remember the beginning of my lecture, we don't know that because there is an occlusion, and beyond the occlusion, everything is unknown. Next. This is a picture from Upper Egypt, the south of Egypt. You can see the River Nile. Sorry, next. Okay, as we said, after the occlusion, everything is unknown. So I suggest you read this article to know what to expect. Next. This article has lovely illustrations of the different variants of the middle cerebral artery. I will focus on a few of them. In the middle row, we can see a codominant, superior and inferior division. The next one, we can see a dominant superior division. The third one, we can see a dominant inferior division. And if we go to the lower row, we can see a trifurcation. So we need to know what to expect because all of this is unknown beyond the occlusion. Next. So it is always a smart idea. We always tend to use the Townes view or the cranial AP view when we do a mechanical thrombectomy. So when we land our stent retriever in the middle cerebral artery, it is always a smart idea to switch into lateral view. So you can see your stent retriever. If your stent retriever is pointing posterior, then it is in a parietal or a temporal branch, a more straight branch. If it's pointing anteriorly, it is in a frontal branch. Next. This is another maneuver we use to enhance our efficacy. It is called the push and fluff technique. What does that mean? It means that we do not unsheath the microcatheter to open the stent retriever, but either we open a little bit of the stent retriever by unsheathing, then we push on the wire of the stent retriever, and this will automatically unsheath the stent retriever, and it will make it very, very compact, and it will make it very much aligned to the wall. So it could engulf any embolus or any thrombus inside. Next. So this is the difference between a regular technique and the push and fluff technique. You can see on the image marked by the OK sign or the right sign, that the stent retriever is fully opened and it is engaged properly by the thrombus. People also advise to leave the stent retriever for 2, 3, or 5 minutes in order it would expand by its metal memory. Next. This is a photo of me and my baby. We are in North Coast. It's a new city we have in Egypt called New Alamein. It's very fabulous. Next. Okay. Not every clot we encounter are fresh and soft clots and are easy to retrieve by stent retrievers. Some clots are usually hard, and we call them fibrin-rich clots. Blood clots mainly have two components. They have red blood cells, and they have fibrin. If you have more fibrin in the clot becomes more hard, and it becomes more sticky, and it becomes more difficult to pull back by your stent retriever. Next. So what would you do if you do multiple passes, like 3 passes, 4 passes, 5 passes, and in each pass you do something different? One pass you do it from the superior branch, the other pass you try the inferior branch, the third pass you try again the superior branch, and it does not work. The occlusion does not change. This could be a sticky thrombus or a sticky embolus. What you have to do now is use 2 stent retrievers. I call this using the big gun because it usually works. Almost always it works. And this technique, we learned this technique from our dear professor René Chapeau from Essen. Next. We have 2 techniques to do this. We open the stent retriever, the first one, then we insert the next microcatheter into the other branch, the inferior branch, then we open the other stent retriever. The other way, the parallel stent technique, is we place the 2 microcatheters in both branches of the MCA bifurcation, and we simultaneously open the stent retrievers. So the embolus, it will be sandwiched between these 2 stent retrievers, and this will increase your efficiency very, very, very much. I remember when I was a little kid and when I lose my toy or ball underneath the bed, I would get the broomstick and try to push the ball so I can grab it with my hand. Imagine if I have 2 broomsticks, it would be much easier to retrieve a hard to retrieve subject. I prefer the parallel stent technique. Next. Okay, not every occlusion is an embolus. Well, most occlusions are emboli, but not every occlusion is an embolus. You have to keep in mind that this occlusion might be a thrombosis on top of an atherosclerotic plaque. Thrombosis on top of atherosclerotic plaque is the usual occlusion we see in cardiology. If you watch a lot of cardiology work in cath lab, if they have a primary artery occlusion, they go for using a balloon and a stent. They do not retrieve anything because it is not an embolus, but either it is a thrombosis on top of an atherosclerotic plaque. Next. So how do we know? How do we know that? It's all the same. As we said, It's an occlusion and it's a mystery. How do we know? First of all, you try a couple of times and it does not work. You try a couple of times and the artery opens, but it does not open the way you expect it to open. It opens and it is like blurry. And when you do another angiography in 1 minute or two, it re-occludes again. Another thing, if you look at the occlusion and if you look at the arterial tree, you will see the arterial tree affected by atherosclerosis, even if you look at the other side. A very important clue also, if you have an embolus, a fresh embolus, if you try to pass the microwire, it passes very, very easily with no effort. But if you have an atherosclerotic plaque and a stenotic tiny lumen, you will have quite a difficult time to pass your microwire and microcatheter. So these are all clues to keep in mind. Next. So what do we do? Long story short, eventually we will have to place a stent to reopen this artery. As you can see here in this diagram, there is an occlusion. You try to do a thrombectomy and it re-occludes again. If you can guess by the clues I mentioned in the previous slide, you can go straight forward to a stent. So which stents do we use? Best stents, of course, are coronary stents. And the more short the stent and the more small in diameter, it will be easier to push and it will have better trackability and you can deliver it to the site of the occlusion. Of course, when you tend to use a coronary stent, you have to use your guiding catheter, your 8 French guiding catheter, and you have to use a 6 French intermediate catheter because it could be very, very difficult to push a coronary stent across the siphon. If you are not comfortable to use a coronary stent, you can start by using a very small coronary balloon. It will reopen the stenosis and you can place a self-expanding stent like, for example, a detachable solitaire, or it could be a Neuroform Atlas stent. These are examples. Next. This is my lovely daughter. I hope one day she becomes a doctor. And this is the shot we took for a very old tree we have in Zamalek district in Cairo, next to Cairo Tower. Tandem lesions. What are tandem lesions? Next. Tandem lesions. Tandem lesions, they are proximal occlusions before the distal occlusions we have. Okay, we have a distal occlusion in the MCA, but proximal to that occlusion, we have another occlusion. For example, in the internal carotid artery origin. So what to do when you are encountered with a tandem lesion? Next. There are 2 scenarios you can do. But please, if you encounter an occlusion of the origin of the internal carotid artery, before you start to do anything, just take an angiogram from the contralateral side and take an angiogram from the vertebral artery. So you can see the circulation and you can see the circle of Willis. You may be surprised to see the circle of Willis very, very efficient. And this may be like a chronic occlusion. Okay, so please have in mind that before you encounter a proximal occlusion, take an angiogram from the contralateral side and the vertebral artery to have a better understanding. Next thing, there are two pathways to handle tandem lesions. First pathway is to open the distal occlusion first. You go with your tools and you head to the distal occlusion and recanalize the MCA first. Then after that, on your way back, you go and place a stent, a carotid stent, in the proximal occlusion. But the way I like to do it, I like to tackle the proximal occlusions first. So it would give me a clear understanding and make me more comfortable when I work. What I do is I pre-dilate the tandem lesion first by a balloon, and I do not use a coronary balloon. I prefer a peripheral balloon. The difference between both is that the peripheral balloon is an over-the-wire balloon. So I can use it as a catheter. I can first bypass the lesion with the balloon and use it as a catheter. I can take an injection from the hub and understand what's going on beyond the lesion. After I pre-dilate, I place my carotid stent and I go to do mechanical thrombectomy to the distal lesion. Next. This is an example of a case. If we go back 2 slides. Back, please. No, back. Back. You can see here the arrow, the red arrow, it points. We can see here the external carotid artery, and we see the arrow pointing to a small slit of internal carotid artery. It is occluded just at its origin. Next, and next. This is after placing the carotid stent. We open the way. Next. And comfortably, we now could see that there is occlusion of the superior branch of the middle cerebral artery, which was very easily opened by stent retriever. I want to add that when you find a complicated case, like a case with a tandem occlusion or a case where the patient is aggressive, it is always a very, very good idea to use general anesthesia. I like to use general anesthesia in all stroke cases when I can. Of course, some cases the anesthesiologist, he does not want to give anesthesia for some medical reasons, but whenever you can use general anesthesia, it's always the best. You achieve best results with general anesthesia. Next. This is the city of Port Said or Port Said. You can see the lighthouse and the sailing ship. Next. So I've been talking about mechanical thrombectomy. Why I don't talk about aspiration? I don't do aspiration. Why don't I do aspiration? For a number of reasons. I'm not against aspiration. I'm not against people who do aspiration. Of course, aspiration in expert hands it achieves very, very good results. But I think stent retrievers, they have very, very good advantages, and I will illustrate what. In aspiration, you have to be in very close contact to the embolus in order to aspirate it. And this could be sometimes very difficult because the middle cerebral artery, it could be tiny and atherosclerotic in old age patients. To introduce a 6 French catheter up there, sometimes it could lead to complications like ruptures and dissections. Another thing, if you insert your big tools up there, maybe you can disrupt the thrombus. Maybe you can break it away and it could fly away upstream. Next. And if you are unable to be next to the embolus and you start aspirating in a distal fashion, you can lead to vessel collapse and you can achieve like zero results. Next. Another thing which I find very, very interesting and very true is that, can we go back 2 slides, please? In order to do a good aspiration, the catheter and the embolus, they need to be aligned in a straight line. Next. Next. If there is an angle between the aspiration catheter and the embolus, an angle of engagement, the aspiration is not successful. Most of the times it's not successful, but this is easily achieved to pull the embolus by stent retrieval. Next. Next. I'd like to thank you very much for your patience, and I'm happy to answer your questions.
Well, thank you very much, sir. We are very delighted to hear from you. Now we move to our panelist, Dr. Tamim, if he has any comments.
Thank you very much, Dr. Mustafa Farid. I was very happy with the lecture. It is very informative and going in depth to the details of mechanical thrombectomy, which is for me it is the first time I hear about this details technique, which is very important for me and or the audience. I would like to ask you one question, please. Did you inject contracts after you passing the clot every time to see the anatomy after the occlusion?
Yes, every time, Dr. Tamim.
Every time.
It is always good to see and to understand. Whenever you can see and understand, this gives you the best results.
Thank you very much.
Thank you, sir. Now we move to Dr. Naqaa.
Thank you, Dr. Mustafa.
Thank you, Dr. Naqaa.
We have a nice question from Dr. Farid. He asked, how is the guiding catheter wedge in petrosal internal carotid artery?
It is a very important question. You have to, it is wedged when there is no backflow. So if you place your guiding catheter in the internal carotid artery and you place your syringe and try to aspirate, it will aspirate blood. Normally, it will aspirate blood. But if you push it deep and further until you feel some resistance and you try to aspirate and it does not yield blood, it is wedged. But you don't have to do this each time. With experience, you will know when it is wedged. It is wedged when you try to push it further and you find a little bit of resistance. Of course, you don't push hard, because if you push hard, you may rupture the artery. You just have to push it very slowly, very gently forward until you feel the resistance, and of course, no backflow.
Okay. He also asked, would you do internal carotid artery stenting first in tandem occlusion, which is the time consuming?
Yes, I would do it first. I would do it first because it is not as time consuming as you think. It will delay the procedure maximum 10 minutes, but it will make you work on the distal occlusion at ease. It will make you, you have a very complicated case. You have 2 occlusions. If you manage the first occlusion, you convert the complicated case into a standard case, like a standard thrombectomy case, where you have an occluded middle cerebral artery. Then you go for it. But this is my opinion. Some people may argue with my opinion. and some very well-known and very respected operators, they go for the distal occlusion first. But for me, it is more comfortable to solve the puzzle piece by piece. I do not like to go into the unknown. I'm afraid of the unknown. I'm afraid of the dark. I like to have some light first, so I know where to put my footsteps.
What about combined aspiration and retrieval?
It's some people do it. Some people do it. Of course, of course it is effective, but I don't know how far effective it is than thrombectomy alone. I think their efficacy is quite very similar. And in the Arab world, like in Egypt, Iraq, our patients, they usually pay from their pockets. So I usually go for stent retrievers. If it does not work, if it is a very sticky clot and I have more money, I would pay the extra money on another stent retriever. We don't need another microcatheter or another microwire, just another stent retriever.
Okay, we have a second question from Dr. Mustafa. He asked, after putting a stent, how long you maintain patient on antiplatelets and what medication you recommended?
Yes, this is a very, very important question, and this was the nightmare we faced about placing stents, because we all fear the hemorrhagic transformation that happens after thrombectomy. But I learned this from a friend of mine in cardiology. If you are placing a stent in a wide caliber artery, like the internal carotid artery, it's like 6 millimeter or 7 millimeter artery, you don't need to be very aggressive on antiplatelets. So it's very much enough to use like a single antiplatelet, 150 milligrams of aspirin for like 48 hours. Then you can add another antiplatelet like clopidogrel 75. Regarding my regimen, I use double antiplatelet, clopidogrel and aspirin for 3 months. Then I stop the clopidogrel and I use the aspirin for life.
Great. He asked also, do you use intra-arterial thrombolysis?
I don't use it because there is not enough literature to support intra-arterial thrombolysis in the brain. So you cannot do something you don't have lots of info about. So if your colleague or if a relative of the patient asks you, why did you do this technique? Or what is the risk factors of this technique? I think we have very, very limited data from literature about intra-arterial thrombolysis. But my personal gut experience says it is a very strong and it's a very important tool to use. And I think it is much safe as we think it is. I think it is not as much, dangerous as we think it is. It is somehow, it could be somehow safe.
Okay. A question from Dr. Tamim. He asked, if the patient receive actylase, can you go for stenting in tandem lesions?
Yes, of course, no problem, yes. And the good thing about actylase, it has a very short half-life, so I don't see any problem. We treat lots and lots of patients with by thrombectomy who are pre-given actides. It's no problem.
We have two questions from Dr. Zaid. He asked the usual guiding catheter.
I go for Guider Soft Tip by Boston Scientific. This is the 8 French, of course. As I said, this is my go-to catheter.
He asked also, what's the preferred intermediate catheter?
Intermediate catheter, if I'm going to use a stent, I prefer in any intermediate catheter length below 115 centimeter. I use the Cat from Stryker. It's a very good intermediate catheter, and I like the Cat from Stryker for a particular reason. It has a connection, Y connector, short Y connector. So you can use this short Y connector. It gives you more length for the device you are going to use in the intermediate catheter.
We have a question from Dr. Tamim. Do you load antiplatelet drug before stenting during the procedure or after the procedure?
After the procedure. After the procedure. Because it is a big artery, internal carotid artery. It is a big artery. It does not occlude easily. It is not like a stent in a small artery, like coronary artery or middle cerebral artery. Internal carotid artery, it is a big artery. The high blood pressure the patient has keeps it open.
We have a question from Dr. Zaid. Do you use heparinization during the procedure?
Yes, always. It is very, very important because you are using lots and lots of tools. If you are placing lots and lots of tools inside the arteries, if you do not use heparin, you can get a thrombus from areas of turbulence or slow blood flow. So you should have heparinization.
We have a question from Dr. Mustafa. He asked if we have a dense MCA sign. Would you recommend it going for CTA or go directly to the catheter?
More important than dense MCA sign is the efficiency of the emergency neurologist doctor. I go to the catheter directly if my neurology colleague tells me it is a major occlusion. By examination, he can know if it's a major occlusion. But best scenario I like, or best scenario applicable for Egypt, I don't know the situation in Iraq, but this is the best case scenario applicable in Egypt, is we go for MRI stroke protocol. MRI stroke protocol has diffusion weighted images and it has MRA. The good thing about MRI in Egypt, we have nearly an MRI machine in every hospital. We have lots and lots of MRIs in Egypt, more than you can imagine. Each hospital we have an MRI. And the radiology technicians, they are very, very well trained to use the MRI. And the MRI stroke protocol, it is a short protocol. It does not exceed 10 minutes. And it is good because sometimes when we have a patient with stroke and that patient is somehow obese, we do not need to insert like a wide bore cannula in a vein. We can just use the phased contrast MRI or arterial spin labeling to achieve good image of the arterial tree. So I prefer MRI. It answers a lot of questions, especially diffusion, flare, MRA. It answers a lot of questions. But priority first, the gold standard for, or the maestro of the stroke team is the emergency neurologist.
Okay. We have a question from Dr. Ahmed. Is continuous heparinization saline enough, or you use a full dose of heparin?
I don't use heparinized saline. I just used full dose heparin, intravenous heparin. It's more, it is the, you know, it is the thing we know. I want 5,000 units of heparin. It is easy to calculate, and it's easy to manage, and it's easy to reverse. But, you know, heparinized saline, you cannot calculate it as much as intravenous heparin.
I think this is the end of question. Thank you, Dr. Mustafa.
Thank you, Dr.
Thank you.
Mustafa.
Thank you very much.
Thank you, Dr. Mustafa. Thank you. It's a pleasure. It's a pleasure to be here. Thank you, Dr. Tamim.
طبعا دكتور مصطفى انا بدي احكي بالعربي، احنا كنا نعرف عربي. شكرا جزيلا لحضورك. طبعا الصور اللي شاركت ويانا من عائلتك كريمه، سلامي لهم واحد فرد، وكانت محاضره جدا ممتعه حقيقه، خصوصا بالنسبه لي فادتني كلش هوايه. وان شاء الله هاي المحاضرات تتكرر اكثر من مره بلقاءات مستمره ويا حضرتك.
إن شاء الله يا فندم، وأشكر حضرتك جدا، وأشكر دكتور مصطفى. وبصراحة أنا يعني استمتعت جدا واستفدت بأسئلة حضراتكم، ويا رب يبقى لنا نصيب نتكلم على الاي في امز في محاضرة أخرى إن شاء الله بإذن الله.
إن شاء الله نتمنى تفرغ لنا من وقتك الكريم.
إن شاء الله يا فندم، إن شاء الله، إن شاء الله.
شكرا جزيلا.
شكرا يا فندم، شكرا يا فندم، مع السلامة، أمان الله.
شكرا جزيلا. Thank you for waiting for the end of the webinar, and we would like to inform you about our upcoming event, the first Iraqi Stroke Conference, inshallah, at the end of the year or the next year. And we invite you to follow the Iraqi Stroke Network on the social media, and invite you to become part of the network by registering yourself. And have a good night. Thank you very much.